Hey everybody, many of you know that I'm a purist when it comes to PRP. I started using PRP almost 20 years ago. At that time, we were adding PRP to our bone graft to augment it around hard to heal fractures and around spine fusions. It wasn't until around 2008, 2009 that PRP really became mainstream in orthopedics. In 2008, Hines Ward, the wide receiver for the Pittsburgh Steelers, sustained a medial collateral ligament injury to his knee, and his physician at the University of Pittsburgh injected that medial collateral ligament injury with PRP. Not only did he return to the game very quickly, but he was actually to return back to full play before the Super Bowl, which the Steelers went on to win. So with this happening, PRP became a subject in the mainstream media. It was on TV, it was in Sports Illustrated, and so we had patients come to the office asking for it. There were a handful of orthopedic surgeons around the country that adopted it into their practice, including myself. I started a PRP clinic January 1st of 2009 and began looking at PRP and experimenting with PRP from that time forward. Today, I'm looking at the difference between leukocyte-rich and leukocyte-poor PRP. The study that I have up on the screen that we're highlighting is a study that came out of Chicago. It came out of Rush University Medical Center, their sports medicine department. Specifically Dr. Brian Cole. And what they did is they did a study that actually had four arms. The control arm, the knee was injected with saline. There was a study arm where the knee was injected with hyaluronic acid, one of the preparations commercially based, such as Synvisc, and then there were two PRP arms. There was a PRP arm that was injected with leukocyte-rich PRP, and a PRP arm that was injected with leukocyte-poor PRP. And what they did is they looked at the outcomes, and they looked at that using the WOMAC score. And what the WOMAC score is, it's a score that was developed in Canada. It's the Western Ontario and McMaster's University Osteoarthritis Index. And what it does is it looks at pain and function of a joint, mostly used in knees and hips after treatment. And the outcome of this study was very interesting. If we use placebo as the breakpoint, placebo showed about a 41% improvement of symptomatology in the patients. Below placebo, below a saline injection, was both leukocyte-rich PRP and hyaluronic acid. The only thing that caused improved symptoms above the control was leukocyte-poor PRP. This is very interesting, and it shows that really the gold standard at this point is using leukocyte-poor PRP. This study was done in 2014. Now, at the same time that this study was being done, the University of Pittsburgh was performing a study as well. The University of Pittsburgh has always been a leader in PRP, and they were actually doing a benchtop in vitro study. And what they did is they took a culture of tendon stem cells, and they added to those tendon stem cells both leukocyte-rich in one arm of the study and leukocyte-poor PRP in the other arm of the study. And then they looked at the production of new tendon tissue from those stem cells. And what they found was in the leukocyte-rich PRP, they actually found degradation of the stem cells and very high concentration of inflammatory cytokines and enzymes to actually break down and degrade the protein and collagen within the tendons. On the leukocyte-poor PRP side, they saw the exact opposite. They saw anabolic changes, they saw proliferation of the tendon tissue with very low numbers of inflammatory cytokines and very low concentrations of degradation enzymes. Now, it's interesting that these two studies were going on concurrently. One as an in vitro study at the University of Pittsburgh, and then the in vivo study performed in Chicago at Rush University. And their outcomes really show the same results. In the patient study, the best outcomes were in the patients that were injected with the leukocyte-poor PRP. In the benchtop study, the best cell cultures were the ones that had 10% of leukocyte-poor PRP added to the stem cell culture. Now, can we extrapolate this data? Obviously, we see that it works in knees. Obviously, if it works in knees, it's probably going to work in hips. But what's it going to do in the aesthetic and sexual health field? It's my feeling that I think that we should use the best quality PRP that we can find. This is typically a double spin process. We want PRP that's going to be anywhere from 4 to 9 times baseline concentration of platelets and growth factors. And in order to get that concentration and to get a leukocyte pore preparation, we need that double spin. So I think that we would see better outcomes in aesthetics with things like the vampire facial and vampire facelift. We'd see better outcomes in sexual health with the O shot and the P shot, and we can use the data from this study to extrapolate that into those fields. If you have questions about the PRP that you're processing, about your centrifuge, how to get better outcomes, feel free to reach out to me. I will place my email address and a link to my website below the video. I hope everyone has a great rest of their week and a great weekend. Look forward to putting out another video next week and talking to you all very soon. Have a great night. Bye-bye.